An AED is an important part of the adult chain of survival. The chain of survival when somebody goes into cardiac arrest is early recognition. So recognizing that somebody has stopped breathing and that their heart has stopped. Early access into the 911 system, early CPR, and then defibrillation. So the defib is a device that does not jump start the heart. So many times we've probably seen it in the past on TV where they may have put the paddles on somebody's chest, or they connect these electrodes to the patient's chest and they administer this shock and the body jumps. Well, what happens is that electricity passes through the heart and it doesn't start the heart, it actually temporarily stops the heart. So in your normal electrical conductive system, everything flows really well, the heart beats normally, but if you have ventricle fibrillation or ventricle tachycardia, there's certain nodes in the heart, and the main node, the one that starts the whole process, is the sinoatrial node, SA node. That's like the spark plug for the heart. That sends the electrical current through the heart to cause the correct beat. So a normal sinus rhythm would be our regular heartbeat. Well, if something happens to the heart, or there's damage to the heart, or something disrupts that flow of electricity through the heart, then that can cause an abnormal rhythm. I like to, especially where we're on a podcast and we're not seeing a lot of visual, what I like to refer to when I talk about how the heart beats normally and how it beats abnormally is to think of being at a stadium. Being at a stadium, a lot of times when we're at a game, or when we were at games before we had this pandemic going on, which we have right now, you would be at a game and somebody would start the wave, or a group would start the wave, and it would go around the whole stadium and look like this normal rhythm, almost like the normal rhythm of the heart. Well, let's say you get a few people that are disorderly, want to do things whenever they want to do. Maybe they're a little bit intoxicated. They may do the wave their own way. So now all of a sudden our normal rhythm of the wave going around the stadium is not so normal. It looks kind of weird. Then some other people say, yeah, I'll do whatever I want to do too. So all these little nodes of the stadium, kind of like the nodes in our heart, are firing at their own beat. So it throws off the rhythm of the heart. And if we were to see a heart that's going through this ventricle fibrillation, which is the lower chambers of the heart, just shaking like a bowl of jello, that's what we would see. The heart's just shaking, but it's not squeezing like a normal heart. Therefore, if we were to check that patient's pulse, there's no pulse felt. So there's activity in the heart's moving, but it's not moving the way it should be. Therefore, the circulation is not occurring, and that's why we don't feel a pulse. So to convert that rhythm, we have to use a defibrillator. Way back before defibrillators, they used to literally punch the person in the chest on the left side where their heart is. That was called the precordial thump. By whacking somebody in the chest, that would give enough energy, about 5 joules of energy, to startle the heart, and hopefully startle it, and it would go back into a normal rhythm. But let's think about that. Let's think about punching somebody in the chest. That can't be good for all the inner workings of our chest. That could break ribs, could push the ribs through the lungs, damage the heart. So they came up with a better idea. They decided to put electricity through the heart to startle the heart, which is a little better than, of course, punching or having, blunt trauma to the chest to cause the heart to get startled and hopefully go back into a normal rhythm. So by using an automated external defibrillator, we connect these pads to the person's chest, and when the machine decides that their heart or that person's heart's in an abnormal rhythm, that's when it decides to have us shock the patient. So that's when we would press that button, shock the heart, and then go hopefully check. Maybe we have a pulse back, maybe not. If we have no signs of life, no breathing, coughing, or moving, then of course we go back to CPR to circulate oxygenated blood. So The AED, basically they're a lot smaller than they used to be. They used to be pretty large, like the size of a battery for a boat, a marine battery. Now they're much smaller. They're not as small as our iPhone, but they're getting there. So with the AED, the AEDs, they actually have a battery that we have to check to make sure that it's fully charged. It also has pads that expire every 2 years, so we want to make sure if we have an AED where we work, or if we're at a school and we have an AED, that somebody is checking it frequently to make sure that it doesn't need service, whether it's replacing the batteries, replacing the pads. Sometimes they throw error codes, especially if they get super cold. So if you ever go by an AED and it has a red light flashing or is beeping, making a noise, that most likely means it needs service. So we would want to turn that on. It would tell us what service it requires, whether it's, again, battery replacement, pad replacement, or just service in general. So the AED does that self-check every night. So if you most cases, like where I work when I was on the ambulance, it would be checked every shift. Where I work in security, the security vehicles, AEDs are usually checked once a day, but the AED should be checked frequently. So there should be a log kept on when that was last checked. That way, if there is any failure with an automated external defibrillator device, it can be checked to see when it was last evaluated. So another thing about the AED is it has an internal memory that records when we're using the AED. So there is a device inside for quality assurance that we can download the device after use, so we can see what the person's rhythm was, and we can also see when the person was shocked, how many times they were shocked. Some people even have implanted AEDs and implanted pacemakers, and the AED would pick up on that in the internal memory. So we'll talk more about the implanted devices, or we can talk about them right now. If somebody had an implanted AED or an implanted pacemaker, if they're without a pulse, we don't avoid using the external AED. So even though we may know that they have a device implanted in them and hope that that would correct the problem, sometimes it doesn't. So if we're assessing somebody, even though they have that implanted AED, if they're without a pulse, we still do CPR and use the AED, our external AED. It's always best before using the AED to do about 2 minutes of CPR, especially if it's an unwitnessed cardiac arrest. If we weren't sure how long the person's down, we should circulate some oxygenated blood first before using the AED. So the only time we really use the AED before doing CPR is if it's a witnessed cardiac arrest and you just happen to have the AED in your hand. Realistically, how often is that going to happen, right? So most of the time we're doing CPR while we're waiting for the AED to arrive by the patient's side, or we're doing it because we're not sure how long they were down for. So with that, the first step for using the AED, once we're ready to use it, is simple. Turn it on, right? Some of these devices, you open the case and it turns on automatically, but we need to make sure the device is on. The next step, which is another easy thing to do, sometimes not for everybody, but it should be an easy thing to do, is to listen to the device and do what it tells us to do. So the first thing that's going to happen when we turn on the AED is it's going to say, connect electrodes. So depending on the patient's size, we'll either use the pediatric pads or the adult pads. It is important to know that if you don't have pediatric pads, it's acceptable to use adult pads, but to use them the way we would use pediatric pads. So let's say we're working on an adult patient from puberty on up. We'll take the pads. We'll have to clear the patient's chest, so remove all clothing, remove anything on the patient, get things out of the way of the chest, and we have to apply those pads to the patient's chest. Usually one pad will go on the right clavicle, so right upper chest, and then the left lower ribs. So the important thing that's real simple is to look at the pictures on the pads and place them on the patient the way the pictures show us, but to always remember to keep the heart between the pads. So we'll make sure we do that. Now, as far as connecting pads to a patient, there's some things that can cause the pads to not stick. One thing would be moisture. If the person was wet, it's possible that we need to dry them off. So if we pull somebody out of water or they're in water, we need to get them to a dry place and dry them off. Dry the chest off before applying the pads. Another thing that may cause the pads to not stick is a hairy chest. If the patient has a lot of hair on their chest, we need to remove the hair where we're going to apply the pads. Most often there's a surgical razor in the kit, so we can quickly shave off that hair where we're going to place the pads. But if we didn't have a razor, you could use a spare set of pads or tape, firmly apply that, and then rip it off. It sounds very painful that we're like just removing hair that way, but if the patient screams, you didn't need the AED anyhow. So we want to make sure that we get the hair off, apply the pads to that area so it sticks firmly against the chest. We don't want any electricity jumping across the outside of the chest. We want the electricity to go through the body. So the other thing is to look for transdermal patches. Some people may use nitroglycerin to dilate their blood vessels to help the blood flow better through their system. So they may have one of these transdermal patches on their chest. If they have a patch on their chest with a gloved hand, you should remove that patch and then wipe that area where the patch was applied. Nitroglycerin, being a vasodilator, could affect you, so that's why we don't want to use bare hands. We want to make sure we're wearing gloves. We should be wearing gloves anyhow. We should be using the proper personal protective equipment. So you should have gloves on anyhow, but when you remove nitroglycerin or you have contact with nitroglycerin, no matter what form it's in, tablet, paste, or patch, or spray, we want to make sure we don't have direct contact with that because it could bottom out our blood pressure. So now that we can stick the pads to the chest, the defib will pick up as soon as the pads are connected to the patient's chest, and the next thing it's going to say is stand clear, analyzing patient. It's up to the defib to analyze the heart rhythm and make the decision whether it wants us to shock or not shock. We're not cardiologists. We can't figure out what's going on with the heart on our own. There is no rhythm strip to look at on an automated external defib. Way back there was, but too many people were trying to be doctors and trying to figure out what was going on. In the case of an automated external defib, the machine does all the work. So we just have to listen, and then it's going to say either shock or don't shock. So if it says shock, that patient's in one of those two abnormal rhythms, ventricular fibrillation or ventricular tachycardia, where the heart's going so fast it could lead to ventricular fibrillation. Once it says shock, we're either hitting a shock button when it tells us it's ready to shock, or it may automatically shock on its own. There are defibs that will decide to shock and shock on their own. The big thing is once we press that button or once the defib counts down for a shock, or before we do any of that, make sure nobody's touching the patient, because if somebody is touching the patient when the shock is delivered, they could get shocked, and that could take a perfectly normal rhythm and convert it to an abnormal rhythm. So somebody that's perfectly healthy, if they got shocked, that could put them into ventricular fibrillation because it's like getting electrocuted. So we want to make sure we're clear. This defib's firing at 350 joules of energy. That's a lot of energy, a lot more than the precordial thump, which was 5 joules. But because this has to send electricity through skin and bones to get to the heart, it's a lot more powerful. So we want to make sure we don't get shocked by the machine. So always stand clear when somebody's ready to shock. The person administering the shock, if they're pressing the button, should say, stand clear, I'm clear, you're clear, everybody's clear, shocking on 3, 1, 2, 3, and they hit the button. If the defib's doing the shock automatically, it will do a countdown before it shocks. It's supposed to sense that if somebody was touching the patient, that it won't administer the shock, but do you really want to test that out? I don't. So make sure you're not touching the patient, or none of your body is touching the patient when the shock is administered. Once the shock's delivered, then it's safe to assess the patient.